Okay, welcome. Today, I'm really excited to talk to my colleague, Dr. Maria Sokolina. She is a dentist. She's the CEO and founder of Harmony Dental Arts. She's also the host of an YouTube channel, and she teaches us all about sleep and breathing. Today, we're going to be talking about how you, as the clinician, can collaborate with dentists on your treatment team. I know that I, as a psychiatrist, as a sleep doctor, I didn't really get much training on how to use dentists on the team, but they're often the first ones who are seeing your patients who are struggling with sleep or breathing related issues. So we're going to be talking about some of those things today. We're going to be talking about myofunctional therapy, oral appliances, and answering your questions about sleep and breathing. Welcome to this channel. I'm Dr. Nishi Bhopal. I'm an integrative psychiatrist and sleep medicine physician. This channel is for you as the healthcare practitioner, the physician or therapist who is wanting to learn more about sleep. If that sounds relevant to you, then go ahead and subscribe to this channel. Okay, so let's jump in. Dr. Sokolina, thank you so much for joining me today. Can you tell our audience a little bit about your background?
So first of all, thank you very much for such a generous introduction. And I was really impressed. We met on Sleep 2024, and I always follow your work, and I find your advices are very insightful. So your audience is very lucky to have you as a leader. And I know you teach other doctors about the sleep topic. So that part is really very close to my heart. I'm gonna first introduce myself. I'm a dentist, general dentist, but I specialize in sleep. I'm a diplomat of American Academy of Dental Sleep Medicine. And a lot of people ask me about my story because they hear the accent. So I want to open the cards from the start. I graduated from my first medical school in St. Petersburg, Russia. And after that, dental department. So after that, I moved to United States and I passed my boards and graduated from NYU College of Dentistry, and I did GP residency. And that time, I was searching for my path. I'm a very aesthetic person, and I really like beauty. I want to be surrounded by beauty. I want to make beauty with my hands. And as a dentist, we're very lucky. We can be creative and scientific, and actually we can create something beautiful what can change people's life. So I did a lot of courses on aesthetic. We have full mouth rehabilitation using different materials, but I had that fear inside of me. I was really scared what people are gonna break it. I was just, in my worst nightmares, I was visualizing my waiting room full of emergency patients with my work broken. So that was number one, what led me to that story. Then I thought, okay, if they can break even the best materials, I'm going to position the teeth in the best setup. I'm going to study orthodontics. And according to my aesthetic courses, what I learned, if you create a good occlusion or bite with the front teeth disoccluding the back teeth, patient cannot break it. Happened to be not true. They can still do that. And I was always wondering why. And on my orthodontic courses, I learned it can happen from bad sleep. So we as a dentist, I know for your medical professional audience, a lot of dentists have the same philosophical thoughts or path, mental path, just like me. From aesthetic restorations, they want to see more. They want to see the routes to roots. They want to see the causes of failure. So it's all leading to sleep. It's a different scenario than medical doctors, but that's how it is for the dentists. So I learned about sleep. I follow a lot of sleep technicians. I highly respect that profession. And I learn a lot in the sleep centers about sleep studies and what they do, how CPAP work. So I start doing the therapy with oral appliances. But then with the oral appliances, yes, we can make them really effective because I check my oral appliances with the sleep study. They have limitations. And those limitations, physical part of that limitation, but also in collaboration. I'm talking about collaborating with the medical doctors. And this is my explanation. Maybe it's different for everyone, but I think my field is very stigmatic people have that stigma towards the dentist. We are monsters. We are really monstrous people. We only care about money and those teeth. You know, we just look at one tooth, broken tooth, cavity, cleaning, but that's not true. Dentists are actually very sophisticated people, and they first see the signs of sleep apnea in the mouth. And I call it dentists are sort of Sherlock Holmes of sleep apnea. We see a lot of signs. And for your audience, for a lot of practitioners, psychiatrists, psychologists, therapists, primary care physicians, I believe your collaboration with the dentist can be very fruitful. Because in the beginning of my career, I was knocking, sleep career, a lot of doors to the medical doctors, so psychiatrists and psychologists. I was in a building in Manhattan with 90 psychologists and only 3 dentists. So I tried to establish the relationship and explaining them, but I can see signs of bad sleep in the mouth. And I'm going to talk about those signs in a moment. And they look at me, maybe I'm out of my mind in a way. People are busy. They don't want to think about that. But if you really, you want to make your practice more diverse, you don't have to search for the patient would come to you from the dentist. Because now I'm going to talk about science, what we see. And we see it so close to our eyes, like, 10 inches, depends if you're wearing loops or not. So we see broken teeth. We see obstruction. It's a little defects on the front surface of the teeth, look like a dip, but that's not a cavity. It's from people bending the teeth during the bruxism clenching forces. We see scalloped tongue. I don't know if you know how it looked, but it looked like a festoon tongue. That's from pushing the tongue out of the teeth because tongue does not have enough space in the mouth. And at night, it just goes strictly into the airway. We see really inflamed uvula from constant vibration from snoring. And sometimes uvula can be huge. Also, we see the signs of acid reflux. And I'm sure for a lot of practitioners, they know what acid reflux and sleep apnea, they go so closely together. So we see a lot of signs. And then we have opportunity to develop a trust with the patient because dentists see the patients every 6 months or every 3 to 4 months. So we can have a conversation as well as our team. I'm talking about dental assistants and I'm talking about hygienists. And it's very important what team can sing the same song. So they can really ask the questions, how is your sleep? Does your wife complain of you snoring? And we can start that conversation. But trick is we cannot diagnose the sleep apnea. And honestly, I don't even want to. It's not my area of expertise. I want to find collaborators to be able to refer my patients to, but they can continue this conversation, keeping in mind what we saw the signs. And those signs can lead to the broken teeth and restoration. That's what still make my heart pump very fast from fear.
Thank you for sharing that. You shared so many important points just now. And one thing I actually forgot to mention is Dr. Sokolina has a special gift for us, for you as the viewer. So you can stay tuned till the end and she'll tell you about that. But yeah, so you listed all these signs of sleep apnea that you see in the mouth and the teeth. And it's such an important point because dentists are seeing patients sometimes more frequently than patients are seeing their primary care doctor. And also, even though, like, as a psychiatrist, as a sleep doc, I might ask my patient, like, can you just open your mouth? I just want to take a quick peek in your airway. We're not looking up close with the loops, like you said. And so we're not getting that detailed information that you're seeing. So you as the dentist is often the first person who's starting to notice these signs. And it was really interesting how you said that your interest in sleep came about because you love beauty, you want to help people have a beautiful smile, beautiful teeth. Yet if there's sleep apnea, that could damage their teeth and damage the work that you're doing. And even in medicine, we want our patients to be alive, like alert and awake and vibrant and healthy and all of these things. And if they're not sleeping well, they're not going to be able to experience that. And so many of us come to sleep with that purpose, like, oh, wow, my patients aren't getting better. What else is going on? And often it might be a sleep issue. So thank you for sharing all of that. Maybe we can talk a little bit about what's the role of the dentist in terms of, we'll talk about oral appliances and myofunctional therapy. Can you tell us about oral appliances? We can start there.
So oral appliances, and I can show you the example. Hopefully it would be visible with the green screen, but there are 126 different designs on the market. And I'm going to show you just one of them. It's called dorsal. But now in the present time, we can do a lot of different things with appliances. I have appliances which are as thin as Invisalign clear aligner trays. And what appliance does, we're not talking about tongue retaining device, which I'm not so hot about because I didn't find a lot of compliance. I'm going to show you my toy, what I usually show to my patient. So I said to my patient, this is you. And this is the airway, the nose, the mouth, the tongue. So this is the patient. And when they fall asleep, tongue block the airway. What we do with the oral appliance, we move the jaw forward and we open the airway. There are some, details about this treatment. It's really good, but patient can breathe with the nose. And for a lot of our patients, unfortunately, it's not the case. But in my therapy, I always try to add, let's call it adjunctive therapy, or I call it adjunctive myofunctional therapy towards oral appliance. So let me go back to oral appliance to basic. This is a basic treatment, just like CPAP. It controls the CPAP effect, CPAP detrimental damage to the body, just like a blood pressure pill. If patient doesn't have those episodes, it goes to nice, great sleep with the deep wave and REM sleep, all the stages. If patient have a sleep apnea episode, so this is constantly get interrupted, they cannot get a proper hormone release. We're talking about metabolic syndrome, gaining weight, different things what we, all concerned, but oral appliance can give them that restorative sleep and they can sleep in any position. And oral appliance is not visible. It's sort of like orthodontic retainer, so they can keep the lips closed and hopefully breathe through the nose. And I usually in my practice, and I have a team in the practice, we give around 3 months for that therapy. When we actively titrate the oral appliance, we teach patients how to use adjunctive remedies. I'm talking about tape, I'm talking about nasal patency, and there are other different tricks what we use for people to open the nose, which improve, the quality of this therapy. And after 3 months, we send it back to sleep physicians. So if you work with a dentist and you actually, board certified sleep doctor and treat your patients in collaboration with the dentist, you start with a sleep study and you refer your patients with the referral, with the sleep study. And then approximately 3 months, it depends, because some people can disappear, some people can be not compliant. So there are differences a little bit with the time, and sometimes it can be sooner. Patient have to go back to you for the, let's call it exam, final exam for the dentist. And you check with the sleep study how effective oral appliance is. If you have a luxury of having 3 nights, for example, some sleep devices give that opportunity to have 3 nights reading. That time we can check a different titration positions, or it can be done in a lab. Then the technician wake the patient up and we check the different position, which is very useful because not always oral appliance is going to show the results below 5. And we want to have a different jaw position or addition certain elastic or, some nasal help, what it's going to give the most efficacy of this treatment. And after that, we see patients every 6 months for the first year and once a year afterwards. And we always encourage patients to go back to sleep doctor to check signs of sleep apnea because we are the team and sleep doctor is a captain. So that's the story about oral appliance therapy and how it should look according to the standard of American Academy of Dental Sleep Medicine and Sleep Medicine.
So helpful. That's really helpful. And I think one of the takeaways there is that the oral appliance, it's not set it and forget it. It does need to be titrated. So for any health practitioners who are listening, if you're not familiar with the oral appliance, that's how it works. It does have to be titrated, and then you do another sleep study while the patient is using it to make sure that it's working. One thing that I'm using in my practice now is sleep image ring. This is sleep image. And you can get 30 plus nights of testing, which is really fun, especially for people who have more mild symptoms that might not be picked up on just 1 or 2 nights of testing. And so you can diagnose sleep apnea, and then you can track outcomes. So if your patient's working with their dentist, they're using an oral appliance or doing myofunctional therapy, you can now get multi-night testing with something like this to make sure that it's actually working.
Very useful. And this device, you're talking about sleep image, not only, it's great as a checkup tool, but also it's increased the interest. Patient, for patient to be successful with any therapy, they have to be partners. I use a lot of, Apple Watch reading, like I use a lot of wearables, including the Snore Lab application. This way, patients wake up in the morning, first thing they do, check how they sleep. And if they see the results of therapy on the device, that's going to increase the compliance.
Exactly. It's motivating for them. And who is not a good candidate for an oral appliance? I'm thinking, if a patient has like TMJ, or maybe they've had orthodontia as an adult, or, are there any contraindications or considerations there?
Actually, TMJ, I love this question, and I always get this question from the physician. What to do if my patient have temporomandibular joint disorder, not TMJ, temporomandibular joint disorder, if they have pain in temporomandibular joint or locked jaw or some disorganization, let's say, inside the joint. Number one, the treatment, what we do for temporomandibular joint disorders, kind of similar to oral appliance. And if patient does not grind the teeth, but has some disocclusion, has some space between the teeth and inside the joint, because when patient, not closing so hard together, then it's going to be the space inside the joint. It's actually lead to relief of the symptoms. I cannot tell you what after the oral appliance, everybody not going to feel any symptom for the jaw joint. But for people who have previous disorder, previous history of symptoms, we do very gentle approach. This appliance, what I show on the screen, I can titrate as much as 0.2 of a millimeter. So we're talking about the hair movement of the jaw. And then muscles, they have a tendency to stretch, body have a tendency to get used to this position. And that's how slowly we can move with the titration. I can train the patient to do that every night and do it so little. And number one, when I start my therapy, I get the custom-made bite. And I always ask my patients to check, how does it feel? Does it cause the tension or stress or spasm, or you feel maybe your neck is bothering you from that position? So no, that's not going to be your position. Your position is going to be as comfortable as possible, because number one goal, you have to become friends with your appliance. Otherwise, this therapy is not going to make sense. So we start with that. And second thing about orthodontic treatment as adult. No, that's not a contraindication. I do orthodontic treatment, just like I mentioned, since 2002. And I also have orthodontist in the practice. So I firmly believe in the retention. We do different type of retention, fixed retention, removable retention. And if patient had a previous orthodontic treatment, number one, he has to wear his retainers during the day and oral appliance at night, and AM positioner, another little device, what we made for the patient to wear in the morning for 10 minutes to align the bite. So they wear the retainers to align the teeth, and they wear the AM positioner to align the bite. So this is not a contraindication. But like you mentioned, I do support my therapy very often with myofunctional therapy as a whole or elements of myofunctional therapy. And, I think that's very important also for temporomandibular joint health, as well as, to prevent orthodontic relapse.
That's a great segue into talking more about myofunctional therapy. And I think even for patients who are not struggling with sleep apnea, again, as a psychiatrist, I see patients who have anxiety. And so they might be clenching because of that, or, they have a lot of tension in their jaw and their face. So, even for those purposes, maybe myofunctional therapy could be helpful. So can you tell us, what is
Yes,
myofunctional therapy? How do you do it?
absolutely,
Yeah.
absolutely. I would like to mention but I'm a diplomat of American Academy of Dental Sleep Medicine, and I was on the board of this academy. And our academy recently started having a lot of interest towards myofunctional therapy, and we had some speakers. And that's a very important topic. What dentists who are interested in sleep would be. It would be one of the tools in the toolbox. So, what's myofunctional therapy? That's actually a therapy. I would call it facial yoga, we can say that term, but it's a therapy, physical therapy for the tongue, for the lips, and for the nose breathing. We have 4 goals. Number 1, patients have to breathe through the nose and preferably diaphragmatic breathing. So this you have to come from the stomach. Number 2, having lips as strong as possible, but they can stay together through the night without tape. And number 3, to have a correct tongue position. We call it spot or tongue on a spot. It looks like this. My tongue can be flat with a palate. It's not so easy because some people have a very narrow palate. They have narrow arches, which is one of the signs of sleep apnea as well. As a dentist, we see that. And the last one, that's a very challenging thing because we take a lot of things for granted. We have to swallow just without tongue, without help of lips and cheek. Most of the people, and I can see them even, in the audience or on a screen, not on the Zoom audience, but, when I talk to people outside, they have this, we can call them wrinkles, we can call them, they have cheeks. So that particular sign showing me what they use cheeks and lips to help swallowing. That means the tongue is not on the roof of the mouth. The tongue is not strong enough to be the only one responsible for swallowing. And with myofunctional therapy, we try to reverse it. We try to train those muscles. They're as important as these muscles or, core or whatever muscles we train. They're very responsible for your airway health and for the breathing through the night. And a lot of other factors. They're also responsible for temporomandibular joint health. TMJ has two points, but tongue is a third one. So it's like a 3-legged stool. It needs to have a tongue as a support. Now you talk about anxiety. That's my view on clenching and grinding. We are creatures, human beings, who are the only one what stand on 2 feet. I know some animals can do that too, but they don't do it as we do full day. So it's very difficult to have a balance with us being so asymmetrical as we are. We have a heart on the left side, we have a liver on the right side. So we have a lot of asymmetry. And then we have a world who is constantly changing. So we need to find the balance. We use our teeth to find that balance. That's my view on that. So with myofunctional therapy, instead of clenching the teeth, we train the patients or try to explain to them what holding the tongue on the roof of the mouth gonna give them similar balance as clenching of the teeth. And it's not so easy to clench the teeth if you hold your tongue on the roof of the mouth. But if you clench the teeth, then dentists can see additional signs. They can see the huge thoraces, growth of bone in the middle of the palate or on the bottom jaw next to the teeth. Also, that's another sign what we see. So myofunctional therapy train the airway muscles, what they can withstand breathing through the nose with the tongue suction slightly to the roof of the mouth and lips close together through the night. And hopefully in that position, tongue, it was a scientific article, research shown, and I have a picture, but I don't have that slide to bring on the screen right away. When the tongue suction to the roof of the mouth, the lips and uvula kind of suction towards the tongue because they have a positive charge, tongue have a negative charge, sort of speak, and they all stay in that position and not, an airway, function. That's a soft tube stay in the open position as well because tongue, according to the research, is 70% of the time is the main obstructor of the airway.
That is so interesting. And I've been trying out the Remplenish straw, which helps position the tongue. I wish I brought it with me. It's in my kitchen. But basically, it's a straw. For anyone who doesn't know, it's a straw with a little rubber attachment on the top, and it trains your to do what Dr. Sokolina was just saying about to stay at the roof of the mouth and to be the primary driver of swallowing. So if practitioners are wondering, like, where do I send my patient for myofunctional therapy? What are the resources? What's available? Like, what's the next step?
Myofunctional therapy, I also recommend, that's a great specialist as well as a physical therapy specialist. That's on my channel, what you can see behind me. I try to create collaboration between different specialties, medical doctors, myofunctional therapist, physical therapist, craniosacral therapist, massage therapist. So first of all, in our group, we have a lot of great practitioners from a different state. So if you join the group, you will see the articles by those practitioners. Also, they kind of show their expertise through writing. And I have a lot of interviews from myofunctional therapists on my channel. Yes, there are several organizations in the United States or actually International Association of Myofunctional Therapists, and actually some of the leaders of those association I interview on my channel as well. I don't want to name some, and I've said some, but you can find people who you feel close with and connect with them. They would be more than happy to show you their expertise and what they can do. So if you Google myofunctional therapy, next to you will find a lot of specialists. A lot of them can be speech and language pathologists. Some of them can be physical therapists, and some of them can be dental hygienists. There are different specialties what can have this, area of expertise. They have a special training and exam, so they're very much qualified to work with the patients. And they would keep you in the loop with a progress report. So that's very important what how progress happening, but very important is a commitment factor because patients have to do the training 5 minutes in the morning, 5 minutes during the day, and 5 minutes at night. So this is the way to find those specialists, either through my channel or Google them or through the different associations. And second important thing, you have to have a relationship with them because they have to understand what's important to you, how much you want to be involved or informed, and then they have to cater they have to design the treatment according to your recommendations because as a sleep doctor, you are the captain of the team.
Really helpful. Yeah, that actually gets me thinking about some changes that I want to make in my practice, which are including questions about dentistry on our intake form. So, for practitioners listening, this is something you can include in your intake paperwork when you're seeing a patient. Just add a question about when did you last see your dentist? And, that's a way to just kind of get more information about what might be going on with their airway. And then also looking up myofunctional therapists in the area. I don't think I even know any in my area. So I need to look into that. 'Cause this is such an interesting, I love how you said it's face yoga.
It's a face yoga,
yeah.
100%, because by training certain muscles, you let some other muscles what don't have to work stay still. And in addition to everything, you don't want, nobody wants the face, so, but don't take it for granted. Just the breathing, just as a swallowing. It's, due to the time, I don't want to talk about early development. We're basically talking about adult kind of sleep medicine, but things what happen with the little kids. I'll tell you just that example. I love it. American Indians, we all live on American Indians land. So, breastfeeding was obviously the only way how they feed the baby. And after the breastfeeding, mom would take her fingers and close the baby lips because they know, they observe a lot of things and they notice what if baby breathe through the mouth, it might not be a good survivor of the future adventures of that particular American Indian. So they want to establish the nose breathing. But in our world, breastfeeding sometimes it's hard to juggle, for busy moms, for working moms. So breastfeeding is not such a fashionable trend sometimes. And then even it's a breastfed baby, then food, what we get through those little packages and we suck it in. So it's not such a training for the tongue and it's not such a stimulation for the jaw. If you look at the American Indian diet or African diet, they use a lot of muscles to grow the jaw. But we're eating a soft food. Actually, it's not cool when food is not soft. Like nobody gonna eat the meat in a restaurant if it's really hard to chew. You would be like, no, I'm not gonna eat that. So we prepared for the food what's just gonna be melting in our mouth. But it's also affecting how, how the bone work and, that stimulation. So the second thing, what we eat, the air, what we breathe with a lot of pollution. So a lot of people are prone to seasonal allergy or other allergies. So that's why they don't use the nose a lot. But, it's all these factors, what it's hard to put into consideration, but myofunctional therapy or even introduction your patients to myofunctional therapy can really change the game.
It's so interesting you mentioned that about breastfeeding and then just eating harder foods that you have to chew to help the development of the airway. I remember when I was like, this is, a long time ago, I remember my grandmother made this comment. This is before I was in med school or anything. I didn't know anything about medicine. I was just, young. My grandmother said, kids these days, they don't eat hard food anymore. They don't know how to chew. And I remember thinking like, what's she talking about? Like, okay, grandma, like it's kind of thing that, grandmas and aunties might say. Now, I think back to that comment, she's absolutely right. We don't. And that's why there's so much crowding, malocclusion. People are, they're mouth breathing, they're not nose breathing. So these old traditions, they knew.
They make sense. Mom knows best and grandma know even better. But yes, it is. And it's true. Like right now, it's a pandemic of braces. Everybody have to have braces. Oh, all of a sudden, after the industrialization happened and sugar was introduced, and all these things happened, all of a sudden, it's too many teeth for the jaw. All of a sudden. Why is that? That's why.
Yeah.
And yes, and it's a lot more and more conversation. I'm writing articles for magazines and, about that, but it's a direct connection. It's so clear what, if this apartment for the tongue is very small, tongue is going to end up here. And actually dentists can see that.
So fascinating. Thank you, Dr. Sokolina, for sharing all of this knowledge and information. There's lots of actionable tools here for practitioners to take away. You have a free gift for the listeners. So can you tell us about that? And then tell us more about where people can find you if they want to learn more.
Or I would be very honored if people in this audience can find me, and I would love to share their expertise with my community, sleep apnea, breathing, snoring help. We are on the Facebook, and you can find me on the Instagram. I put it here, Dr. Maria Sokolina, and I'm on the YouTube and LinkedIn. And my channel is, interview with the different people, different practitioners around sleep area, just like I mentioned, my functional therapist, physical therapist, sleep doctors, because I try to provide all possible resources. So now we're talking about free gift. I created, I'm going to share with Nishi the link of what you can find on my website, drmariasokolina.com. It's called survey. It's a myofunctional sleep survey. You do the self-assessment, how ready you are with myofunctional therapy. And then after this assessment, you get the YouTube video with different exercise what you and your family and your friends and your patients can do to improve the muscle tone of the tongue, of the lips, and the breathing. And I hope that's going to provide you better sleep with a lot of dreams.
Thank you so much. I think I'll sign up for that too. That sounds really cool.
I would be very honored. So thank you very much for this opportunity to share with the medical community the main idea what we as a dentist equipped with a lot of tools to help sleep practitioner to get patients better, make them more refreshed, less tired in the morning, have energy to wash the floor, to do the morning run, to get through the day without nap, hopefully, and not to wake up at night gasping for air. But most important, as we all know, what 25% of the population have a sleep apnea or some type of related upper airway resistance syndrome, and 87% of them undiagnosed. So we all here in the same boat to help our patient community and find the puzzles of this disease together. Thank you for doing that, what you're doing, and I really honored to be here.
Well, thank you so much for coming on and sharing your knowledge. I feel like we could keep on going, and we didn't even get into kids in too much detail, so maybe we'll do that another time, but really appreciate your time. And everyone, I'll put the link to the free sleep myofunctional assessment in the video description below, and then Dr. Sokolina's links to find her on YouTube, Instagram, and Facebook, and LinkedIn will also be in the video description. So check that out, and thank you, everybody, and I'll see you next time.
Thank you very much.